what do you see in the future? What do you see a path to improve outcomes for patients with relapsed refractory myeloma? I think that's where we are now, right?
Yeah, so I do want to briefly mention two other, I think, therapeutics or drugs that I think are going forward. So one is selinexor, and as we know, selinexor is approved for use. And there was actually a couple presentations at ASCO virtually. There was the Boston trial, was randomized of selinexor, Velcade-dex versus Velcade-dex, and an improvement triplet over doublet, surprise, surprise. But there also was a combination of selinexor with daratumumab and a combination of selinexor with carfilzomib. And those were given, when they're combined with another drug, it's given weekly, and I think it's a little bit better tolerated. So I'm looking forward to seeing weekly dosing of selinexor with some of these other drugs to hopefully improve the tolerability of that.
Yeah.
And then the new CELMoD, so the next.
You do give, quite a lot of pre-medications with the selinexor. We have like a cocktail that we give, patients. Yeah. Yep.
And then the new CELMoDs, there's the CC220 and CC940. I think the CC220 is iberdomide.
Yeah.
Dr. Loniel presented that. I believe it was at ASH, showing, a response rate in POM failures, upwards of 30%. And then Paul Richardson presented data on the most recent CELMoD, the CC, or what he called 940, which basically had a response rate that was over 50%, which is pretty amazing, actually.
It is.
And he showed some impressive results in the extramedullary disease, a person that had a big liver lesion that disappeared on this combination with dexamethasone. So I think going forward, those drugs have to move forward also, maybe together with some of these immunotherapies, together with bispecifics, together with ADCs, maybe a post-CAR maintenance. The drugs that we have now, 5 years from now, I don't think we're going to be using most of them. We're going to have all these novel drugs. That's what I think we're moving forward to, which is pretty amazing.
The CELMoDs are really, the iberdomide CC220 was really very tolerable in the phase 1-2 trials. And in fact, Alliance, it's now at CTEP for it's looking at combinations in 2 or more prior lines of therapy. And it's really, in patients who are DARA. It was studied also in DARA refractory and then the POM refractory. And it was like an amazing, each drug has like a 30% response rate in like DARA refractory patients. So it's really nice to to have these these drugs in clinical trial. But again, after you've used all these drugs, or in patients who who have continued relapse and refractory, for the patients who have who relapse within 2 years, in all of these treatments, I have to say, I'm going to put a plug in for allotransplant, okay? In all of these treatments, these patients are going to relapse. Allotransplant is the only chance for a possible cure in myeloma, right? 20% of patients may have a cure, but of course you have to use it early. So there was a study, so a meta-analysis that was just published, looking at 1,083 patients that did auto-allo versus auto-allo tandem transplant, and showed that the after a median follow-up of 118.5 months, the median overall survival was 98.3 months for the auto-allo compared to 78 patients. And then go think about the allo. If they relapse and you give reinduction, retreatment, their myeloma versus disease effect takes over. So the graft versus disease effect also takes over. And it showed that actually patients who relapse after auto-allo actually did also better in terms of PFS post-relapse. And it was 62.3 months compared to 41.4 months in the tandem transplant. So, using it early. And, we have, there's a clinical trial through the BMT-CTN 1302 that closed early because it was a slow accrual. And I think the reason for that, it was initially held off, closed for like some toxicity, and then reopened. And that slowed the accrual. But after it reopened, those who got accrued, we had like 5 patients on that trial. The toxicity was very minimal, and patients, we've had a few patients who relapse and they actually go back into a CR after reinduction of treatment. So allo is an option out there for the young patients, young and fit patients who relapse early.
So I think that our portfolio of drugs and what we have coming down the pipeline is just a tremendous and amazing for all of us. And we definitely need to devise strategies, a multi-pronged approach for the newly diagnosed patient, which can really induce a rapid and deep remission, and hopefully allow us actually to step back from the continuous therapy model, hopefully be able to take patients off therapy, and so that they actually can have some, basically quality time being off therapy. And maybe there'll be a percentage of patients, an increased number of patients, where the myeloma will never come back. I actually think one of our goals should be not only to get to a limited time frame of therapy, hit people hard and fast for a year or 18 months or 24 months, and then give them a break, but also to try to get rid of some of our most toxic therapies. So I do think that transplant, whether it's auto or allo, I think those are our most toxic for sure. If we could get rid of those as part of the envelope for frontline therapy and give people more longer quality of life and potentially actually cure some, maybe 20% or a third or more, that would be in my mind the holy grail. And that's what I think we should be going forward with.
Yeah.
How about any final words from you, Yvonne?
No, a lot. I'm excited about the way things are going in myeloma, and I'm so excited to be a part of it. And the more we have, I try to enroll patients in clinical trials even at first, relapse, because that's the only way we're going to have more drugs and approve more drugs. So clinical trial is number 1 for anything. And then if there's none, then you choose from the others that are available. So it's been a great, discussion, and I look forward to working with you, Dr. Martin, in the future.
Absolutely, absolutely.
All righty.
Discussion.
Thank you.